Okay, welcome everyone. We are so excited today to have an expert with us who's going to talk to us about trauma-informed care. We have Melissa Elliott Brogan. She's going to tell us a little bit about her experience. She is a private practice owner, and we have a connection here. We are both DSW students at SUNY Buffalo. So this was kind of by chance that we overlapped, which is really exciting and fun. So I will do our housekeeping first, and then I want to make sure we have plenty of time to share with Melissa of what we have her here today to talk about trauma-informed care, which I think is so all-encompassing and can reach any setting that anyone in the field is working with.
And it really is where the field is going. So I'm excited about it. Thanks, Megan.
If it's not there yet, it needs to be there.
100%.
So a little bit about me. I'm not gonna to read this all, but I am a child and adolescent psychotherapist in private practice. I live and practice in Washington, D.C., and I'm working on my play therapy credentials. So I'm very big into expressive arts, play as a modem to connect, play as a modem to heal. Also, I'm the founder of Agents of Change Social Work Test Prep. I love learning about learning. So this was a great bridge for me to kind of bring my love of learning with social work. And then some of my areas of interest there, that the list could go on and on and on. I'm interested in tech and innovation, so I use that a lot. And then I'm also interested in multicultural supervision. Melissa and I, before this, chatted a little bit about our love for supervision. And yes, and I also work primarily with neurodivergent youth and children, so that's a big passion of mine as well. And then I am also a DSW student at SUNY Buffalo. So now we have Melissa. I'm going to read this about her. Melissa Elliott Brogan is a LSCSWR. She was telling me about that process, which was a very long additional process to get reimbursed for. The R stands for reimbursement. Is that
Yeah,
correct?
it stood for reimbursement. You needed to get that back in the day to be able to be reimbursed by insurance. And then that kind of switched and changed during the pandemic. But
Yeah.
it really denoted that you did 6 years post your graduate degree in supervision, and you had to clock all those hours and do an additional 2,000 hours of clinical hours that were with a mentor or supervisor that you had to, yeah, set up for.
Oh,
So it was
she's
definitely something,
very
definitely,
seasoned in the field.
right. Right.
She's currently a clinical social worker specializing in trauma and owns a trauma-informed group practice. That's what we're going to talk about today. And she has students that are interning at her private practice. I'm going to let her talk about that when we get into her stuff. She has tons and tons of certifications. She's a clinically certified trauma professional. She specializes in anxiety, panic disorders, OCD, CPTSD, personality disorders, bipolar, DID, self-harm, severe and persistent disability, all the very, I would say, that can be difficult to treat diagnosis. A lot of people don't specialize or don't have the expertise in these areas. So I can't wait to hear more about that. I'm not going to read here, but she uses a very eclectic blend of theories, frameworks. I'm the same. I kind of pull what works for me, and it's very client based, right? What you're
100%.
utilizing.
Yes.
Um,
I really
has
have to like tailor make that I guess tailor to the needs of the person that chooses you to work with. Yeah.
Absolutely. Like a lot of people are like, what framework do you work under? I'm like, a lot of different ones because it's
Right.
different for everyone.
Right.
She worked early in her career in psychiatric social work, and then you said you've been in private practice for
For about 12 years now. Yeah. So
yeah.
I kind of felt called to do this side of the work after being in that psychiatric care facility settings, and really recognize disparities and how maybe I could improve care for
Mhm.
individuals that maybe were only relegated to going to some of those clinic settings that individuals deserve to be also in these other, beautiful spaces that were
Yes.
trauma informed.
Absolutely. And we'll get into that. We're going to get to
Right.
talk more about that.
Right.
Just some logistical stuff. Our learning objectives for today. Participants will be able to apply the principles of trauma-informed care. We're going to talk what some of the key principles are of trauma-informed care. What does this look like in practice? What does this look like for a therapeutic environment? And it will look different in every setting, right? What you do in private practice probably looks very different than what trauma-informed care might look like in a hospital or in a school. Develop culturally competent trauma-informed practices. that is really at the crux of providing trauma-informed care. You have to be mindful of the different, um, what the client brings to the table, and that could be whatever identity they bring to the table, or it could be intersecting
Mhm.
identities. That's a big thing. And then lastly, participants will be able to adapt trauma-informed care for various populations and settings, knowing that it's going to be different for every setting. Why is this important? I think that it enhances therapeutic outcomes. I think that's the number one most important thing. If you're not providing trauma-informed care, your outcomes are not going to, personally, I think they're not going to be as strong as if you do provide trauma-informed care. And there is research to show that trauma-informed care
100%.
works.
And
People
it's
wouldn't be
really
doing
not
it.
right. It's really not person-centered at that point. It's really what the clinician denotes instead of what the individual is asking or wanting support in. So I think that it really flips the script, right? And
Absolutely.
dismantles the hierarchy.
Yes. We'll get into this more. I have some thoughts about this.
Yeah,
We want
sure.
to promote equity and access in mental health care. Melissa's talked a lot about how everyone deserves the highest level of treatment, and oftentimes our marginalized populations do not have access to or have not been provided high quality or don't even have the access to the high quality care. So we'll talk about how we can make care accessible. And then lastly, we want to prevent re-traumatization. I have many times talked to clients that said coming to therapy actually was not by intention of any part, but it was re-traumatizing to them due to a variety of different things, that maybe the space was not set up that was in an appropriate way, or they were experiencing microaggressions, or there was some implicit bias. So there's a variety of different things that come up when we are talking about trauma-informed care. So that's kind of the logistics, but I want to kick it over to Melissa. Melissa, thank you for being here. We're so excited. Can you just tell us a little bit about what made you start your private practice and when you started to develop your practice and your work to be trauma informed?
Thank you so much, and thanks for having me, Megan. I'm really excited to talk about this topic, and it seems to be very much in the buzz of what is the now, right? But trauma-informed care has been around for quite some time, and really at its core, it's basically, and I'm going to say this, and maybe we'll talk more throughout our conversation. It's doing less on the clinician part, and just allowing oneself to sit back and to listen, right? I think we've gotten so heavily. Um, I don't want to say indoctrinated, but we've gotten so heavily from the very concept of what it means to establish a therapeutic alliance with different modalities and different ways of performing, where the very basic concept of sitting with another human being and listening to what somebody has to say and not knowing what to do, I think is an element of what trauma-informed care at its core, right? First and foremost, we want to promote safety. So what I
Yes.
found in working in psychiatric care and in clinics and in spaces in my years of kind of growing in the field was that there was really, really great people, but then, and really great modalities, but then the delivery was somehow, getting contorted or getting, it was a very convoluted process. And really just being able to sit with somebody and allow whatever time frame it took to get through whatever situations that were being presented really wasn't afforded, and I wanted to change that. I went off and branched out so that I could structure the time frame and how I wanted to conduct the therapy, or at least provide the opportunity for the therapy to occur in that way.
That's amazing. And I guess that leads me kind of to a follow-up. How does this new, I would say it's a paradigm shift, right? It's a new way
It
of
is.
being with. I'm all about stretching my way of being taught versus my way of where I want to go.
Right.
How does seeing care from this trauma informed lens differ from traditional therapy, or maybe what you learned in grad school, or what we all like learned that this is by the book? How does it differ from that?
I have to say, trauma-informed care requires the clinician to really sit with their own biases, with their
Mhm.
own prejudices, right? A huge component of trauma-informed care relies on the countertransference piece. And I know from working with students and from all different universities and colleges and institutions, some places frown upon even discussing countertransference and even see it as bad. I've had students relate to me that, oh, my professor in school said that this is not something I'm supposed to explore. And I'm like, right, we don't want to fully disclose all elements about the self because it's not our therapy. However, the element of what you incorporate in that conversation very much builds this congruence through the therapeutic alliance, and that's what's missing. So there is a great article, and I could definitely give you information on
Yes.
that. It's called The Reparative Quest. It was written many, many moons ago, but kind of really speaks to the importance of the countertransference piece that we as clinicians recognize to be able to utilize in a way to reflect back to the people that choose us to work with. So I know that was really wordy, but saying when you have something come up in you, what's the system in which you recognize it and then utilize it in that session, saying, ah, like I'm starting to feel this element of sadness. Are you feeling
Mhm.
sad? Right? Because I'll never know you're sad and you'll never know mine, but you know sad and I know sad and we connect in that way. That's the empathy. It's not understanding. It's not saying I know. It's saying, are we able to meet in this mutual space that is equitable so that we can format whatever next steps you'd like to take?
I love that. And that got me to think so much. It sounds like, and you can give me your opinion, it sounds like so much of trauma informed care is connection. You cannot get anywhere unless that's my biggest like word these days is you're not going to get very far or you're not going to get anywhere in the therapeutic relationship if you don't connect. You got to connect at least on some level.
It's so true, and I would say that and, thank you for that mutual connection is vital in to all the work that is done because sitting in this seat, right, being the therapist, we automatically are disarmed in our connection to other people because we love people, we wanna help. A lot of us go into the field for these right reasons. We tend to lose the focus of what it means to walk in that office and be on the receiving end. So the connection from our vantage point is quite simple. The connection from somebody else's can be quite complicated. And I think that humbling oneself and having that cultural humility and that ability to not be competent, but to be willing to learn how to comprehend what it means, right? And I always say to other clinicians, I do have the fortunate ability to work with other clinicians for supervision. What is it like when you first walk into a doctor's office? And not that we're all doctors, but what does that feel like to sit there on that table, to sit there and wait for someone to come in the room, to sit there, have to tell your story one more time? And I think at the core, again, trying to simplify things and allow oneself to sit with the concept of what does this all mean bigger picture? Like pull that camera lens back. And that's what I'll
Yeah,
say.
I use that analogy a lot. Would you want to go back to a doctor's office where they don't greet you, they don't make eye contact? I've had this experience many times, and it's not, I have a lot of empathy that the system is probably broken, but it does not make me encouraged to go back another time. And I think that's why it's so hard to find a good provider, right? That you feel comfortable with. And you shouldn't come to the therapy feeling like, oh, I have to do this, right? Oh, I have to
Right.
keep showing up to this place. So I totally agree that it's about find as the provider too. I never forget that it's not lost on me how much vulnerability it takes for someone to seek us out. How many times do they maybe just find us like, through maybe word of mouth or just cold search? Like, how vulnerable is it to say, I want to work with you? Like, that is just not ever lost on me. That takes so much
100%.
courage right there.
I agree. It is such an honor to walk with an individual on their journey and to be chosen and not to, you know, and, and to find that how can I say that? How to find that space within that relationship, but also know that that relationship is okay to end. And if you are no longer able to provide that care or service, then allowing that individual the autonomy to go, which I found that in people that maybe comprehend trauma informed approaches, that
Yeah.
doesn't mean you're providing trauma informed care, right? Trauma informed care from phone call to every element that is along that therapeutic journey really needs to be patient centered, person centered, patient focused. It's really not about you. Like I tell people,
Yeah.
like, you're doing too much. Like I'm always like, do less, do less, do less. Sit back. If you're doing more work in that session, then that's your therapy. That's something we need to be reminded that it's really about promoting safety. You want, peer support, those six
Yeah.
elements from SAMHSA, right? Trustworthiness and transparency, collaboration, empowerment, and choice, and then cultural humility, and then, affirming care
Yes.
between gender, all these elements that that we speak very highly of, I think, in circles of us that are in higher education or have been in the field sometime. But what does it mean again to, on its very simplest form, be the person walking in the door? And I think that's the element of trauma informed care.
Yeah, and I love that. I think this ties back to that piece that you said countertransference exists. I always say to people that are new to the field, have you, this is countertransference. I don't know why we don't talk about it. Have you ever been super excited to see a client because you're doing
Yes,
really good work? Have you ever had a client that you're like, oh, like this is a very difficult, that in itself is countertransference, and we need to
100%.
name it for what we, at the end of the day, we're human beings, right?
That's
If
right.
we're robotic about it, they're not going to get the best level of care and we're not going to be as effective as possible.
I mean, I 100% agree. And I always, again, share with other clinicians, it's not what you do, it's who you are. So,
Yes.
and there's a few studies. I had taken some trainings with Dr. Eric Gentry, who's a leader in traumatology. And one of his greatest notes that I've ever taken was that there have been studies and meta studies, and I have information to give to you, to give to your listeners, in that, there have been studies in saying what is the best form of trauma therapy, what modality, so we can all just go to it, right? Why would we waste time? And at the end of the day, when you put it through that meta-analysis, most trauma therapies come out even. They're around that
Yeah.
80% effective, right? What's the hook? What's the piece? It's the therapeutic alliance, it's the relationship. So whatever acronymed, different modality you want to pursue because you have a passion, that area, DBT, IFS, CBT, MI, um, all of these shake out similarly. Now, my concern, I guess this is further in our conversation, is that sometimes clinicians, right, that are newer to the field kind of latch on to some of these
Mm-hmm.
modalities and they become a little pigeonholed, and they're eclectic in nature because how some of these modalities are meant to be implemented come with a little bit of artistic interpretation, right, with any of these pieces. And I think that that is a disconnect in our field where we're not doing the specific Dr. Francine Shapiro EMDR. Maybe some are with the 8 session lead in, bilateral stim. Most are interpreting that and doing it as a portion of the other eclectic work they're doing, but we're not talking about it. And if we're not talking about it, then we're not able to promote it and collaborate, which is part of that trauma informed care.
Yes. So my last question on this topic is, what do you think are some misconceptions? I hear so many people trauma informed care, but maybe there's a misconception about what that is, because I think it's actually takes a lot of work on the person, the provider, to actually work in a space that's trauma informed. So what are some common misconceptions, or do people sometimes check the box and say, yes, I'm trauma informed? So what are some misconceptions or myths that you see around this? Because you hear it everywhere,
You
but
do, you do. And I think coming back to, there are trauma informed approaches and there's trauma informed care. And I think that
mm,
from my experience, that you don't need to overhaul your practice with information and training sessions to have this trauma informed care piece. We don't want to perpetuate treatment bias by believing that we have the answer to someone's problems, right?
mm,
So I think right there and then sitting back again in the seat and doing less, right? We discover this path together and delivering the elements of what in the field through your education, through your experience, hopefully through your supervision and your case consultations, that we wind up needing to do less and sit back and hear what the next steps are to take. So trauma informed care really has to incorporate safety and being open and receptive to what the individual who chooses to work with us is wanting, and constantly checking in. So again, another element of some training that I've had is after session, you ask individuals, how is this for you? Is
mm.
this what you had set out to achieve when you made that phone call and you came to meet with me for the first time? And at first, sometimes the people that work with us are all too quick to go, no, this is great, you're great.
Wonderful. Yeah.
But by the fifth, sixth time you ask, they're going, well, I really didn't get a chance to say that piece. We kind of went off on that tangent. Or, I have some other things I'd like to incorporate. And you say, you know what? Please let me take a note of that and let me
Mm,
put it on our agenda. So the misconceptions about trauma-informed care is that it has to be something specific, focused, and with an acronym attached to it and a certain measured way. True trauma-informed care is a journey that we walk with someone on. So it needs to be collaborative every single moment of every single conversation.
This just came up into my head. So when you were saying this, I was thinking trauma informed care is being with, not being for. You're not there for the person, you're there to be with the person.
100%. It's for when people that come into the space and with this virtual care, it's definitely been difficult. I liken it to walking into somebody's living space and being able to offer them um, an experience, right? We don't want it to be something like you go to the store or a shop and you purchase a service or you purchase an item,
Oh.
right? It's not this, it's not that it's nuanced in a way where it's experiential. It's not supposed to be
Mm.
something you pick up at a store off a kiosk. So I think more often we kind of lose that element of what it means to just sit with somebody and not
Mm.
feel the pressure to produce something. It's just
And
a
that's very westernized culture, right? How many, do you get this question? 2 weeks in, okay, like, do you think maybe in 3 weeks we'll be like done, right? I always get that, like,
yes,
I've come like, maybe 2 to 5 times, like, is our work over? Because in Western culture and right, insurance only provides so many sessions.
100%.
We sometimes have this thought that I'm gonna go to therapy, I'm gonna get better, they're gonna give me coping skills and I'm out the door. And that's not how humans operate. Healing is not linear.
No, and and thank you so much for saying that. Years ago, I had taken the training through the NASW, believe it or not, on how to levy what's considered expectations of somebody coming into therapy and saying, like, going on this journey, we're going to discover what the path is together. And again, much akin to the Wizard of Oz, when Dorothy said, "You can click your heels at any time." The coping skills we have are within us. So I definitely share with individuals that coping skills. This is not a treasure map that we have to go on to find like this magical coping skills. I don't have your answers. The answers are within the work that we will do together, but there's not anything we're trying to achieve and there's no time frame for that. It's as your comfort level denotes and as I check in with you to see is this aligned with what you were looking for and do you feel any difference, right? Not do you feel better, are you seeing any change, are you maybe having different thought patterns, do you notice anything? And sometimes in the beginning, I also say as well, sometimes we feel worse, right?
Yes,
Coming in for kind of shaking up the sediment of whatever's been dormant. That doesn't mean going back in somebody's trauma experience. That is not needed. Going
right. Not
back,
flooding
right?
them.
I always say things sometimes are dormant for a reason. We've got an incredible system within the body with our defense mechanisms that we don't need to unearth trauma, but we can certainly talk about how you feel knowing that there are things that have gone on in your life that have maybe been prohibitive. And I think that that's the other element of that.
A lot of times it's just awareness, right? Oh, I didn't know that. I numb myself out by doing this thing, or because it's worked for them for so long to protect themselves.
100%. And I often say that I'm in a very privileged position to be objective. So my ears catch things when people say them that people sometimes aren't aware of. So that
Yes.
awareness, I think, is the first step in kind of just actualizing what the heck's going on here. When we start to separate that a little bit and become more mindful, then we start to have awareness that we can maybe alter the script or maybe do things a little differently and try to see what those results might be.
Or throw the script out. I tell
Yes, 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 yes.
I have a big problem with like canned scripted.
Yes, yes.
They're great for a framework, but they lack us, right? They
I
lack
mean,
the
right.
humanity to it. It's great, like, yes, but then I could also just give that manual to them themselves for them to do.
100%. That's like, going to a seminar and just seeing the slides and you're like, well, I want to have the conversation. But that's also very person-centered, right? I love Rogerian.
Yes.
That's how I was trained in my coming ups. And my mentor, whenever I would go to my mentor, Marty Rosalinsky, thank you for all that you've done for me in the field. He would often say like, "Okay, that's great, Melissa. Like that's great." If I had like some newfangled, modality or this, I'm going this training, and he'd be like, "That's great. How do you feel?" And I'm like, "Oh," like it would always come down to what was I contributing to whatever the
Yeah.
situation was, and you know what, he was right. And now that I mentor and teach, I often find people going, "But what about this? And what about this?" And I'm like, "Okay, that's great. If you like that, now what about your own?" And how do you feel? And people, I see it on people's faces going, but my classmates and my cohort, they're doing these things with these, different systems and going for these trainings. And I'm like, okay. I'm like, if that's what you want, but it's really, again, it's you in a seat. It doesn't matter what you know and what you do. It matters what is the person asking of you and how to respond to that.
Awesome. We'll flip gears a little bit because I think this is very important. And I am very big into multicultural supervision. How does cultural humility play? It, I'm guessing it plays a very big factor in trauma-informed care. How do we meet people where they're at and respect, but not, what word do I want to say here? How do we respect their differences and their identities, but not push our own ideas about where they want to go with it? I'm just thinking sometimes we think someone wants to go there and they're just in therapy to talk about this like identity that is marginalized, but sometimes like I'm not here to talk about that at all. So how does cultural humility inform what you do as a clinician, and how do you have these conversations with people that maybe have intersecting identities or that are different from you? Because I mean, we have privilege here, we're white women, right? That's not lost on me either. So how do you incorporate cultural humility into your work?
Thank you so much for bringing this up. Again, this is something that we're needing action in now.
Mm,
First and foremost, when being sought out in therapy, my recommendation is to go back to those very simple principles of safety. And in speaking with someone, saying, is there a way that I could help or assist or guide or support you in promoting better safety? Am I someone that you'd want to visit with and have a consultation by? And is there someone else that I might connect you to in the field? So I believe that building up a referral source, if you will, of individuals in the field that may be able to sit with and be present with and affirm some of the care that I may not be able to connect to due to implicit, explicit biases that we're also in charge of deconstructing, but we're not supposed to be doing it on, to how can I say, it's like on the backs of individuals looking
right.
to be with us, right? Like we're not wanting to take our time to say, oh, this is my opportunity to go now get this training just because I have this individual from this protected class of people who wants to work with me. Oh, I could do it, because that's how social work was started, right? By affluent, white privileged
Yes.
women. We're like, oh, I want to give charity. So we want to be very,
Charity
very
work, right.
cautious, right? Not to be charitable in our contribution to the field, to be equitable and to recognize the diversity. And then the inclusivity is including a broader network of opportunity to
Yes.
connect individuals to services that are appropriate.
I love that. And as you were talking, I wrote the word choice, giving people choice, giving them agency. I'm just thinking of when I first started out, there's no choice. They're assigned to you. You work with this person, right? And I might not be the best fit for them. And
Correct.
just think of a system then that is not being trauma informed. I could be someone that I look a certain way and that could actually be worse off for the therapeutic relationship. I think a lot of times we have egos and we don't want to, we can do it, we can do it, we can do it, but that doesn't, we can do it, but that doesn't mean it's the best situation or that that's the choice that someone is going to make. Also, a lot of marginalized populations don't know they have choice, right? Like they've
100%.
never been told you tell me when this is not working for you, right? So I really think inclusivity and choice and having a very, very meaty referral network is so important because we're not for everyone and that is okay.
And that's okay. But what we can do is allow, like whatever that privilege is that we're afforded, we can allow it to almost fill spaces where there isn't access for other individuals and other voices, just to open up whatever passageway that can be, and then quickly sit back down. I think what's important is you're sitting what it means to have privilege, and
Yes.
that being a clinician doesn't mean that I get to impose my will on a person or situation. There's a natural hierarchy that comes with being in this seat that needs to be dismantled as much as possible. And wanting to create a safe space and trauma informed care, we've been talking a lot about the micro work, but the meso and the macro work is that the entire organization needs to be trauma informed.
Yes.
So, providers, clinicians, staff, the way that the office is looking or, structured, it's so that the entire process is something that we help welcome individuals into and have an experience from, again, first phone call to the last moment that they're out that door, so that people know that they matter, right? People know
Yes.
that they're that it may not be the right fit, the right time, but then there'll be a memory to come back to that if and when that does occur. It won't leave such a negative impression that people then internalize. And we've seen what happens when that happens,
Yes.
right?
And we don't want it to be where people have a negative idea about what therapy is and they're never going to come back, right? That we have just done more damage then, right? If we
100%.
have provided a space that was not trauma informed and not welcoming, and now they're never going to take that because, like we said, it's so vulnerable to even make the step.
Right. And then, what would inspire somebody to want to do that? And I hear often when people coming like, I had therapy before, it didn't really work out well. I didn't like what happened. So I'm giving another try. And I say right away, well, then let's find out what's going to be the best next step for you. And if I'm not it, you keep my phone number and
Yes.
and I will do my best to connect you to services. I can't promise that that's going to
I,
be, because sometimes, for as much as we have networks, a lot of people, as you know, are full, a lot of
yes.
systems are closed, a lot of insurance situations are changing. So there are so many barriers to be able to, but at least trying, showing somebody that you're willing to take that effort. Something else to briefly mention too, early in the field, I come from a social worker mindset, right? I am a social worker, and I'm also a clinical therapist who provides psychotherapy. But some people like don't find that to be intersecting and say, "Well, you're a therapist. Like you don't do the social work, you don't do the phone calling, you don't do the team collaboration." And I disagree. I
Mhm.
think being trauma informed means that we create and establish networks so that we can plug into and provide that team approach. That's the one element that I miss about my CDT, clinical day treatment, and pros,
Yep.
personal recovery oriented services days. We'd get together on most mornings and have a treatment team meeting. And that was to find the best ways to approach situations and serve people better. I don't find that we do that enough in private
Yeah.
practice. And we need that through supervision. But that's developing that PCN, that good old PCN, and being able to have people to call upon to be able to provide that additional support.
Something that you just said, I worked in a school and I was having a conversation with someone last week about schools, and it's similar with different settings. Private practice can be very isolating, right?
Yes.
Schools, this person said schools is actually meso macro social work because it's community work. And I was like, oh my gosh, yes, it's
Yes.
community work. And I just forget sometimes, and that's my own, I need to remind myself that in private practice, you have to build your own community because it's just not made for you. So that's building up that network, because it can be very isolating. It can be very, oh, this is just my specialty. And it has to be tailored. So I had 3 follow-up questions for you that came to my mind with being trauma informed, starting with the space. So I'm thinking here, and you can tell me your thoughts. I was talking to someone last week. They said I have pictures of my space up on Psychology Today, and she said I've had people say I felt very safe just by looking at your pictures, and I that for me was affirming. So that in itself could be trauma informed care, is knowing what the space is going to look like.
100%. I think, again, whatever we can do to provide somebody an opportunity to make a decision,
Yes.
based in their own autonomous thought processes, allows for that trauma informed piece. And that's the same that goes for staff and clinicians and providers, saying, this is what I can do that may or may not fit what you're looking for. But if you'd like to try this out, then we can take that journey. If it's not for you, I have these other resources available. But I agree with you. Giving people an opportunity to see what somebody's walking into allows for someone to feel more safe, I would say, so it's like there's no guessing and you don't have to feel anxious just about the initial walking in the door.
There's that piece. Website's a big one too. Like I'm a big like, you got to know what you're getting yourself into. The website is really an opportunity for people to get to know you better, right? So I'm very much like, I tell clinicians like, your website should represent you. It should
100%.
it should absolutely, if you hate your website, like what does that say about yourself if you just have this thing, or it's like really just kind of not welcoming or appealing. And then also I was thinking in reaching out just for the initial, like why it's so important. I do good fit calls. I'm not going to have someone come and we're not a good match. So I think the importance of like making sure it's a good fit before you even bring them in is so
I think,
important.
you absolutely, you said it so well. And I believe that sometimes just that initial consultation call can just say, this is what I offer. Does it seem like that's something that
That
you'd want to
works
work
for
with?
you.
And then
Yeah.
also what you're presenting with is just beyond my scope of practice. And again, that humble piece will help you and the individual who chooses to work with you better. Otherwise, many people just want to take someone who's coming through the door. Oh, I don't work with couples. Oh, I don't work with, individuals, or I'm not part of this community, or I think I can, oh, I've always wanted to try that. That is, again, not the opportunity to do that. You go to supervision, you talk to somebody that's an
Yes.
expert in the field, you can get the training and then work with somebody to be able to implement that care under supervision. Otherwise, it's actually perpetuating treatment bias, which I think is rampant in the
Yeah.
healthcare industry. A
Yeah.
lot of organizational culture, and if you Google this and look it up, it's based in white supremacy. So
Yes.
interestingly enough, dismantling racism and how we conduct ourselves in that therapeutic alliance, not only is trauma informed care, we're also providing opportunity for correction that hasn't been for some time.
Yes, and this kind of segues. I'm going to share a way that I think that I was very honest with a client before I even started working with them, and then I'll ask you if you have any examples. But like I talked about our ego, sometimes we want to be like, we don't want to say, you know what, I can't do that. And especially I think if someone comes by word of mouth, you're like, oh, they really want to work with me. So I'll give you an example. And then I want to hear how you maybe have seen this and you have had to say, you know what? I will help you. I'm going to connect you with the right person, but I might not be the person. So I got someone passed along to me and I was probably the fifth or sixth person. And for me, that's always like, what is going on here?
Yeah.
And it was a very complicated case. They got bounced to me because the client was neurodivergent. And I got on the call with parents and I just kind of got some info. And I said, you know what? Thank you so much. I'm not going to be another person that just let's start working together and see if it works. I said, I think your child needs a higher level of care.
Mhm.
And I will help you find this higher level of care, but you're just going to keep getting bounced to person to person. There's a reason why there's been six people. Um, and I said, do you know what they said? They said, we actually were waiting for someone to tell us this, that there was a higher level of care needed, and no one did. And they said, I'm actually so thankful that you just said, let's not try this again. We've been there, we've done that. So thank you. They just needed me to validate that this was not working and that they weren't the problem, right? And they were so frustrated, right? And it's like that for me was being trauma informed because what was happening was they just kept getting bounced around and it didn't feel good, it didn't feel right, and their life was becoming untenable with the needs of their child. And I said, your child's neurodivergent, but that's not what's going on here. A higher level of care is needed.
Right. And I couldn't agree with you more. I think having those professional boundaries and
Yes.
again having that ability to discern our own limits, right? We all have limits and that's what great supervision can do. That's what being able to be in trauma informed spaces and then having that trauma informed care from again every element of what that means because without being able to, I would say, shake hands with one shadow side, right? That's all that Jungian piece that I love, like
Yeah.
welcoming in and like the different parts, but saying, I have limits and I have limitations. And there are some individuals that my heart might want to help, but I'm not the right person and I'm not the right fit. So being able to be a source of support and resource maybe in transition because like you say when I call it the bat phone. I got the bat phone when people call me and go, Melissa, I've got a situation where the individual hasn't been able to be placed somewhere and doing something. I'm like, well, what's going on? Because then that person is now believing that they're untreatable, that they're a
Yes.
problem, and it winds up in being internalized by the very vulnerable individual who is deserving of good care. So I think that all survivors of trauma that have challenges, and they're not challenging, if that makes sense. So
Mhm.
where people like, and that label gets attached, like this person's difficult. So I'm thinking that we need to move away from labeling and from our own biases in order to just sit there and say, hey, is there something I could do to support you? And then be truthful. This sounds like this needs a higher level of care, but I've
Yes,
got so and so to
right.
hand you off to.
Yes. Do you have any experiences where in that first initial conversation you have kind of realized, I'm not going to be the person, but I will help you get to that? Maybe that one's really sticks out in my mind because the parents were so thankful and
Sure.
just relieved to hear it. Like I didn't want to be the bearer of like this news, but they're like, thank you.
Sure. I mean, and I have to say, yes, I have people that, and again, I think this comes down to being aware of your ego and allowing yourself to know. I, I believe that I have an ability to communicate, and I definitely think I come across with some warmth. So when I talk with people, some people would like to work with me, but that doesn't. But that's when the therapist has to do the work, right? Has
Yes.
to be able to sit within that space and say, I'm aware of the power I bring in that conversation where I may be the first person out of 20 that picked up the phone call, or
Wow.
the first person out of 20 phone calls this person has made that answered them back. So that is such a very delicate situation, saying, I know that I'm answering your call, but from what you're saying, I really don't think I'm the right fit for you.
Yes.
And that is, we might inadvertently or directly disappoint someone, and being able to, again, process that with countertransference in supervision, that we don't take something, or take something for granted, or take someone on that we really aren't skilled to work with just because our heart's in the right place. Then we're going back to that very basic treatment bias, charity
I
giving.
can help you.
Like,
I
oh,
can
like I
do
feel
this
bad.
for
When you feel
you.
bad, that's countertransference. And I think that again comes from higher education, being
Yes.
prepared. What does it mean to be a clinician? A lot of social work, higher education programs are graduating many, many students who want clinical care, haven't had clinical internships. And some of those clinical internships haven't had adequate supervision. And as an intern, you're kind of not forced, but you're encouraged to take any case that you're given to explore. But then when you get into these higher spaces, you realize that really perpetuates treatment bias, because I might not have been the right fit. Plus, being so green as a student, you don't really have the skills to be able to sit with individuals that have been through some significant situations, mostly trauma, right? How does anybody work with a survivor of trauma? That takes years of developing those
Yes.
skills.
Oh my gosh. I'm so happy you discussed this. I was at a conference last week and it was someone presenting from Canada and she owned it's very different there, right? There it's a different healthcare system. And she said for trauma, she works with a lot of trauma cases. She will not put interns on the case because she said what's gonna happen in 2 to 3 months, they're gone.
That's right.
And
That's right.
what is for clients that have experienced trauma, they don't need someone that's like a revolving door. And it's nothing against the intern themselves. It's just, can you commit 2 years to this person, right? Because that they need stability in their life. So I sometimes think we don't even think of those things, that our systems are set up to churn people in and out, or the what has the highest rates of turnover, right? Like
Correct.
mental health, like all these places where the needs are very high and they're not getting the care that makes the most treatment sense for them because systems, talk about macro, are not set up for them.
Right. You just bring up such a great piece, going back to that trauma informed care and the organization and the necessity. We're not providing adequate support and supervision where individuals who are out of school, right, getting your first beginnings, people are just putting the time in to get the hours, to get their C certification, get their clinical certification to move on, because the spaces are so not trauma informed, right? They're
Yes.
waiting all of these stresses. And then we come to this other piece of secondary traumatic stress and working with individuals that have trauma. We've seen through the literature, right? And that's something that I actually work on for my DSW, is how can we improve our ability to communicate about the need to prepare individuals for the work. I don't think that that's being done adequately from my time in the field of almost 19 years, from the spaces that I've been invited to be in. I really think that we need to do better for our students and our very new clinicians in the field. If you come out in a way that you think this is how it's going to be done, well, then you see somebody get their LCSW in New York, we get the LC, then that's it. Then you open up a private practice, then you develop a group practice, then you get interns, and the cycle just keeps on spinning. And what we're not doing is the trauma informed care work from even school, from even that higher education.
Yes, and my hope is that, and academia moves much slower than a lot of other systems, so we know that it's takes time to like it's not just like, oh, I want to create this course, okay, you're going to take it. It takes a lot of time, and it takes, just because once again, a system we work in, like
Yes.
pushing up and advocating for these different things is necessary. Part of being a social worker is advocacy, social
But that's
justice.
also meaning that the system allows for the voice. And I don't want to vilify higher education because I think it's so important, especially now in
Yes,
2024, we have restorative conversations. You know,
yes.
this hasn't been done well, but I do think for the most part, most individuals in the field have good intentions.
Yes,
The road to
absolutely.
hell is paved with good intentions, they say. You can have all the best of intentions, but not know how to apply the service. And that still imparts, like you said, microaggressions, treatment bias, and prejudices. So it's not just about having good intentions, it's having the restorative conversations of how do we sit back and do better. And again, I'd say do less, right? Because there's a lot of there's a lot more clinicians in the field, and New York State has kind of changed how people are licensed. You used to have to come out of school, take a test to get your LMSW, and then 3 years later, 2,000 hours later, take an LCSW exam, and then 3 years after that, and 2,000 more hours and supervision, you could get an R. So it used to be 6 years postgraduate work, which I went through to get my R certification that denotes I've spent at least 6 years honing my craft as a clinician. Now you only need the first three. And there is no way to tell how long somebody's been in the field and has
Yeah.
worked towards that. So I think we need better diversity, equity, inclusion, and affirming practice on how to prepare clinicians for the longevity. And
Yes.
when you really have trauma informed care, you wind up not, you kind of subvert burnout, because what trauma informed care is an entire systemic approach to being comforted, supported, and appropriate, taking time for self-care, which is vital for the work that we do. So you don't have to be in that moment where you're frantic, and then what are you imparting on the people that choose you?
Right. This was all wonderful. But we're right up to the end of time here, but I do want to ask you one last thing. How, if you're looking towards the future, where do you see in 10 years from now trauma informed care evolving to?
So I think that that is a great question. I'd like to see that we start these conversations, that we start these restorative and important conversations on what it means to truly be trauma informed. This is my interpretation, but I'm not the end all be all. While I do consider myself an expert in the field of trauma, I'm only an expert because of the individuals that I've learned from. Other
Mhm.
individuals have learned from other experts. I would love to start those conversations and compare notes, which I don't think we get to do as often in private practice, right? We need more consultation and connection and networking with each other. Hence, the PCN is so vital to the work that we do.
Yes, I love that. And that's kind of shaped the Melissa and I talked before this, the more we get into this field, the more we know we don't know. And it seems counterintuitive, but please, so my word of advice is I am very much like reach out to people. I
100%.
wouldn't be nowhere without having people to kind of bounce ideas off of. And I'm a person that just loves to connect and learn and learn about different people's things. So I tell people, reach out to people on LinkedIn. Like, what's the worst they could say? No, right? Like a lot of people are very willing to take the time, especially if that's their expertise. I get very geeked out about it. I'm like, yes, I will talk to you all day about it. Reach
100%.
out and grow your network.
And I think that we would all be surprised at, like you said, how much you don't know and how much we have to still learn from each other.
Yeah.
And on LinkedIn, I developed the DSW network. People even say, "Oh, you're getting a doctorate? Oh, what's it in? Social work? It's a DSW." They're like, "What's that?" So I
Right.
think that there's still a lot that we can do connectively within the social work realm to be able to support one another, but ask those questions, get to know people,
Yeah.
network, and I think we
About
can develop
connection. It's
better
all
spaces.
about
Yeah.
connection.
I love it. And we're all really jazzed, right? Whenever you speak to another social worker, you get like this real excited piece of like, like we want to, we are those change agents. But again, I think humbling oneself, checking the ego, and
Yep.
being able to sit in spaces, and also be comfortable with not being invited to certain spaces, right? Be comfortable with it
Yeah.
not being you, even though you might have all the gumption and the wherewithal, doesn't mean that you're the person for the job. Making sure
That's
that
okay.
it's okay. Yes, there's plenty of people. There's 300 million people in the United States, right? And we only have, I don't even know how many social workers, but I think there's like 2,500 of us in New York, or I could be totally off in that number, but there's enough people for every person. So don't hold on to the people that, that would be better served by someone else, for whatever those situations might be.
Well, this was wonderful, Melissa. I want to thank you. I will also link onto this. Melissa's going to share those resources that she talked about to get a little bit more in depth with some of those resources. There's tons of stuff out there, right?
Yes.
Just explore a little bit more. But I just thank you so much for your expertise. We can have many, many follow-ups to this, which I
Yes,
hope.
I would love it.
But
Self-care.
yeah, self-care, more at the organizational level, what we can
Supervision.
supervision. So,
Yeah.
I know we will be talking more about these important topics, Melissa, but thank you so much. And thank you for taking the time to share your expertise with us today.
Thank you so much, Megan. Thank you for the space.
Thank you.
Thank you.
I hope you enjoyed this social work CE from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or the link in the description to purchase the course and take the post-test. If you're looking for more CEs, check out our unlimited plan. You'll get unlimited access to 150 plus ASWB approved continuing education courses for one low annual fee. We're always adding new courses and bringing on new experts. Did I mention we also have 5 free CEU credits available too? Check it out at agentsofchangetraining.com.